Hi there, my very highly treasured, valued and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for all healthcare workers. The Virtual Clinical Pharmacy Institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very, very crucial and non-negotiable to us. Here, we seek to remain your premier source of very crucial tips for high-impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some very useful tips which may prove very, very handy in your line of duty. So I welcome you all to part 117 of our Pharmacotherapy MCQ series, Measuring in Infectious Diseases. Welcome. And the first question reads, Mrs. AKW, a 36-year-old female patient, presents to your accident and emergency department with a chief complaint of an abscess on her groin, and she tells you she experienced fever at home. The emergency medicine consultant does an incision and drainage and sends a sample for culture and susceptibility testing. This lady has a past medical history of polycystic ovarian syndrome, and you establish she has no known drug or food allergies. Some of her vitals include a slight fever of 38.2 degrees centigrade, heart rate of 82 beats per minute, blood pressure of 119 systolic, 79 diastolic, and a respiratory rate of 20 breaths per minute. The emergency medicine consultant initiates Madam AKW on cotrimoxazole, Septrin, and plans to follow up with culture results to adjust the antimicrobial therapy depending on these results. On day 3, the clinical microbiologist uploads the following results on the hospital intranet. They've grown Staphylococcus aureus with the MEK-A positivity, and this bug is susceptible to linezolid, vancomycin, cotrimoxazole, and doxycycline, but it is reported as resistant to both clindamycin and oxacillin. So my question to you is, which of the therapeutic decisions listed below would be the most appropriate after reviewing the above lab results? Would you choose to continue therapy with cotrimoxazole for 10 more days, or would you change to doxycycline at a dose of 100 milligrams orally twice daily for 10 more days, or would you continue with cotrimoxazole Septrin at a dose of 1 DS tablet twice daily for 7 more days, or would you do a total switch to oral linezolid at a dose of 600 milligrams twice daily for 1 more week? I'll give you 10 seconds to choose the correct answer. I would opt to continue with Septrin cotrimoxazole for another 7 days. Now, a MEK-A result is indicative of methicillin resistance. I would like to start by underscoring that. Linezolid would be efficacious for treatment, but it is expensive and should be reserved for more serious infections or for infections that do not respond to other first-line therapy, and that makes answer D incorrect. It would be an overkill. then changing to doxycycline would still be efficacious, but this is unnecessary because the patient already takes Septrin cotrimoxazole, which is effective, to which the bug is susceptible. So that makes answer B incorrect as well. Then I would like to add that in addition, 10 additional days of therapy would be too long because the patient has already received 3 days of an effective antimicrobial, Septrin to be specific, and that makes answer B incorrect. Therefore, in my opinion, the best answer would be to continue with cotrimoxazole for another 7 days to complete a 10-day full course of therapy, which makes answer C the correct choice in this particular case. Let's move to the next question, please. And the next question reads, Mr. JGK, a 68-year-old male patient weighing 137 kilos with poorly controlled type 2 diabetes mellitus, is scheduled to undergo surgery in your OR for a right total hip arthroplasty. He is reported to be allergic to penicillin, and the last time he took penicillin, he had nausea and vomiting. Now, the orthopedic surgeon calls you as the clinical pharmacy specialist in the infectious diseases team, seeking recommendations for perioperative antimicrobials. Mr. JGK has healthy renal function. His kidneys function just right. So my question to you is, which of the agents listed below would you recommend for use as a prophylactic agent perioperatively in Mr. JGK's surgery? Would you recommend the use of clindamycin 600 milligrams infused over 30 minutes, an hour before incision, or would you consider cefazolin at a dose of 2 grams IV, co-administered with metronidazole at a dose of 500 milligrams IV, or would you settle for 3 grams of cefazolin, or would you opt to infuse vancomycin at a dose of 25 milligrams per kilo IV over 2 hours? I'll give you 10 seconds to choose the correct answer. I would be biased towards cefazolin dosed at 3 grams IV infused over an hour. Now, cefazolin provides coverage for MSSA. It also covers streptococcus, susceptible strains of E. coli, Proteus mirabilis, and even susceptible Klebsiella pneumoniae. Now, this coverage is adequate for most types of surgeries unless there is potential to encounter anaerobic or other pathogens. Now, we know that this is an orthopedic surgery, so there is a very low likelihood of perforating the gut, which would lead to spillage of the anaerobic bacteria. Now, the correct answer, in my opinion, would therefore be C, because it also requires a dose as high as 3 grams for a patient whose weight exceeds 120 kilos. Remember, this patient is around 137 kilos. I'll refer you to a table 1, in the recommended doses and redosing intervals for commonly used antimicrobials for surgical prophylaxis in the ASHP 2013 guidelines for appendectomy procedures. They tell us we should use cefoxitin, cefotetan, cefazolin, And cefazolin in that case should be co-administered with metronidazole. Now that is not the type of surgery we have in this case, so answer B would apply to appendectomy. Now answer D is incorrect based on the milligram per kilo dosing, which should be 15 for vancomycin, not 25. Then answer B is incorrect due to the cefazolin dosing 2 grams would be too low for a gentleman who weighs 137 kilos. And even the addition of metronidazole would be inappropriate. Anaerobic coverage is only required for specific types of procedures that I have mentioned earlier. Now the same table I referred to earlier, table 2 of the surgical prophylaxis guidelines 2013, drafted by the ASP, clearly outlines this, so I would refer you to it. I would recommend you read it. Now answer A is incorrect because nausea and vomiting is not a true allergy in my opinion. Therefore cefazolin should be administered. Let's move to the next question, please. Our next question still refers to the patient above, Mr. JGK. 10 days after his surgery, he has purulence and an erythema at the surgical incision. A CT scan of the hip shows superficial edema with no evidence of fluid collection. He has a body temperature of 99.4 degrees Fahrenheit. His WBC count is 8.9 times 10 power 3. And there's a 4 cm surrounding erythema around that incision. So my question to you is, in relation to Mr. JGK's case, which of the surgical or pharmacotherapeutic plans listed below would be the most appropriate for him at the moment? Would you opt for incision and drainage plus vancomycin IV for 48 hours, then switch to linezolid oral 600 milligrams twice daily to complete 7 days of antibiotic therapy? Or do you feel incision and drainage only would suffice? Or would you do incision and drainage plus vancomycin IV infused for a 48-hour duration? Or would you settle for cephalexin 500 milligrams QID for 7 days without incision and drainage? I'll give you 10 seconds to choose the correct answer. I would settle for incision and drainage only. I'd like to start by saying that suture removal plus incision and drainage alone is an appropriate course of action for patients with no evidence of systemic response, like this particular gentleman. Now, evidence of systemic response is defined using temperature, white blood cell count, heart rate, and the size of the erythema or induration. This patient does not show any signs of systemic response, therefore antibiotic therapy isn't warranted, and that makes answers A, C, and D incorrect in this particular case. Let's move to the next question, please. It's still referring to the same gentleman, and it says JGK presents to the surgical clinic 60 days after the initial implantation. The orthopedic surgeon notices a draining sinus tract along the surgical incision. So my question to you is, which of the diagnostic criteria listed below would be the most appropriate for diagnosing JGK with prosthetic joint infection, which we abbreviate as PJI, according to the IDSA guidelines? Would it be A, radiographic, CT, or MI imaging suggestive of diagnosis? Or would it be B, a single positive tissue or bone culture collected intraoperatively? Or is it C, elevated ESR and CRP? Or would it be D, presence of an actively draining sinus tract that communicates with the prosthesis? I'll give you 10 seconds to choose the correct answer. Answer D, in my opinion, is correct. The presence of an actively draining sinus tract that communicates with the prosthesis. I would like to start by saying that the IDSA PJI guidelines state that the presence of sinus tract communicating with the prosthesis is definitive evidence of prosthetic joint infection. The other answers may contribute to diagnosis, but they don't carry any strong evidence of recommendation. I'd just like to add that ESR and CRP should not be used alone, but they can help if clinical evidence isn't apparent. I would just like to add that multiple intraoperative cultures growing the same organisms or not a single culture are recommended. And remember that radiographic evidence alone can help with hardware loosening, but clinical evidence is needed to determine presence of infection. Let's move to the next question, please. And it reads, which of the statements listed below is correct concerning antibiotic treatment for prosthetic joint infection in the case of Mr. JGK above? Is it A, a longer duration of therapy is required for infection caused by MDR gram-negative pathogens rather than susceptible pathogens? Or is it true that if hardware cannot be removed, then 6 months of therapy is recommended regardless of the pathogen? Or is it true that oral therapy is an option for staphylococcal infections in patients undergoing 2-stage exchange procedures? Or is it D, antimicrobial doses for long-term suppressive therapy should be between 25 and 50% of the full initial treatment dose? I'll give you 10 seconds to choose the correct answer. C is the correct answer. Oral therapy is an option for staphylococcal infections in patients undergoing 2-stage exchange procedures. I would like to start by saying that when determining antimicrobial treatment regimens for PJI, it is important to determine what is the status of the hardware and what the pathogen is, and that makes answer C correct. I would like to add that staphylococcal PJI, following what we call a DAIR under 1 stage, must begin within 2 weeks of intravenous therapy, but oral therapy can be used following 2-stage procedures. Now, answer D, in my opinion, is incorrect because the lowest effective dose for long-term suppressive therapy has not been determined in any studies. I would like to add that the IDSA PJI guideline list suggests doses that can be used, but others are used in the literature with good clinical outcomes. Now, answer B, in my opinion, is incorrect because hardware removal enables shorter duration of therapy, that is lasting 4 to 6 weeks. Then answer A, in my opinion, is incorrect because longer durations are needed for staphylococcal, not for gram-negative infections. That is misleading. So I'll refer you all to refer to the IDSA PJI guidelines if I was not very clear. Let's move to the next question, please. So it's still regarding the same gentleman, JGK. Now, after consulting the infectious diseases consultant, the orthopedic surgeon initiates Mr. JGK on vancomycin, dosed at a dose of 1,500 milligrams IV, infused over 2 hours, twice daily, co-administered with 300 milligrams of rifampicin, taken orally twice a day, for the management of the PJI, prosthetic joint infection. Now, based on the intraoperative cultures, which were positive for MRSA. Now, before infusing the 5th vancomycin dose, a sample is drawn to determine the vancomycin trough levels, which are later reported as 13 milligrams per liter. So my question to you is, which of the goal vancomycin serum trough levels and actions listed below would be the most appropriate, assuming Mr. JGK has a weight of 137 kilos and a height of 72 inches, and his serum creatinine is 0.7 milligrams per deciliter? So would it be a goal of 20 to 25 milligrams per liter with consideration of an increase in the dose to 1250 milligrams IV TDS? Or would it be a goal of 10 to 15 with no modification in the current regimen? Or would it be a goal of 15 to 20 with an increase in the dose to 1750 milligrams infused over 2 hours, twice daily? Or would it be a goal of 5 to 20 with no modification in the current regimen? I'll give you 10 seconds to choose the correct answer. I would consider targeting a goal of 15 to 20 milligrams per liter with an increase in the dose to 1,750 milligrams infused over 2 hours, twice daily. That would be the correct answer according to the 2009 IDSA vancomycin dosing guidelines, which recommend a trough serum level of 15 to 20 for serious infections. Now that makes answers A, B, and D incorrect based on the serum level range. Now, therapeutic monitoring for serious MRSA infections is likely to change pending on guideline updates. So in the near future, those figures would change slightly. Let's move to the next question. And it reads, Mr. JGK is due for discharge but isn't fit for acute rehabilitation. He informs the orthopedic surgeon of his inability to infuse vancomycin on his own at home. As the clinical pharmacist specialist in the infectious diseases team, what alternative to IV vancomycin can you recommend for outpatient antimicrobial therapy, what we abbreviate as OPAT, in Mr. JGK's case? Would you suggest tigecycline 100 milligrams infusion once daily? Or would you suggest ceftaroline 1,200 milligrams IV once daily? Or Would you suggest a fixed dose telavancin 750 milligrams infused once daily, or would you suggest weight-based deptomycin 6 milligrams per kilo infused IV once daily? I'll give you 10 seconds to choose the correct answer. D is the correct answer. I would consider weight-based deptomycin 6 milligrams per kilo IV once daily. The recommended PJI dose of deptomycin is 6 milligrams per kilo, which comes to 700 milligrams when we use the actual body weight of this gentleman. And I would like to add that C is incorrect in my opinion, because telavancin 750 milligram fixed dose has not been validated in clinical studies or in any case series. Then I would like to add that answer B is incorrect due to stability concerns with ceftaroline at room temperature. It would not be ideal for this gentleman. Stability at room temperature would be compromised, especially if you opted to give it as a continuous infusion. Now, answer A, although the dose appears correct, it is not the best answer due to labeling changes which suggest an increasing all-cause mortality with a variety of infections. Tigecycline in such seriously ill patients gives very poor clinical outcomes, and there are high rates of mortality. And it has a downside of having a very large volume of distribution, so you are unlikely to achieve optimal serum concentrations that would be therapeutically effective. So all those many ones justify why administering deptomycin at a dose of 6 milligrams per kilo once daily would be ideal. Let's move to the next question, please. And it reads, Mr. PBO, a 47-year-old male patient weighing 87 kilos, presents to your surgical clinic. He has a past medical history of type 2 diabetes mellitus. He has an A1C of 14.6%. His sugars are not well controlled. He also suffers from peripheral vascular disease. He's hypertensive, and he's been smoking 1.5 packets per day. He is also a depressed patient. Today he has a chief complaint of left foot ulcer, not improving despite wound care over the past 60 days. On physical examination, a 4 centimeter surrounding edema is observed, and it's warm and it is purulent. He has a body temperature of 98.6 degrees Fahrenheit, and his WBC count is 7.5 times 10 power 3. He has a respiratory rate of 18 and a heart rate of 83 beats per minute. He tells you he's allergic to sulfur drugs. The last time he took Septin, he had a rash. And concerning his surgical history, he's undergone a right foot transmetatarsal amputation, and that was a year ago. And you established that 4 weeks ago, 28 days ago, he was on cefalexin 500 milligrams, taken orally 4 times daily for a whole week. He also took coamoxiclav 1 gram twice daily 7 days ago, and he completed his therapy 72 hours ago. So my question to you is, what is the severity of this infection? What would be the appropriate antimicrobial recommendation in this clinical scenario? Would you consider it A, severe, and would you consider hospital admission for tigecycline IV, or would you consider it moderate and consider hospital admission for vancomycin, ceftriaxone, and metronidazole, all administered IV, or would you consider it moderate and treat as an outpatient with levofloxacin 750 milligrams orally once daily for 10 days, or would you consider it mild and treat as an outpatient with clindamycin 450 to 600 milligrams 4 times a day for 10 days? I'll give you 10 seconds to choose the correct answer. So answer B is the correct one. According to the PEDIS IDSA clinical criteria, PEDIS, answer B is correct. This is a case of a moderate infection which requires hospitalization and the infusion of vancomycin, ceftriaxone, and metronidazole. And I'd just like to add that moderate infections, like in this patient's case, can be treated during hospitalization using either IV or oral antimicrobial, so long as they have good coverage. I would like to add that answers A and D have incorrect severities of infection, and answer C does not include optimal coverage for MRSA. Remember, levofloxacin does not cover MRSA, so it would not be good empiric therapy for this particular case. So all those many words justify why B would be the best bet in this particular case. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly urge you to remember to give it a thumbs up, to like it, and to share it widely with your peers, and to leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very best is yet to come. Thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your very kind collaboration. And I look forward to interacting with you in part 118 of our Pharmacotherapy MCQ series. Thank you.